Hi, everybody. I hope you can hear me okay. Um, I'm going to cover an ECG today and cover a topic that I think gives a lot of people nightmares whenever they see ECGs like this. Without further ado, let's just have a look at the ECG. So, we're going to analyze this ECG, and I've noticed over the last few years is that when you get an ECG that looks like this, everybody kind of panics. That's the first thing. They panic and they immediately shut down. Now, just jumping a little bit ahead, we're going to talk about left bundle branch blocks. And left bundle branch blocks, for some reason, trip people up. So what we're going to do is use our system that we've been using now for, what's it going on, 2.5 years? 3, I think. And we're going to analyze this ECG, and we're going to go through it step by step by step, and we're going to try and figure out what's going on, because it's one of the easiest things once you get the hang of it, but it's one of the scariest things to see coming out of an ECG machine. And I've noticed a lot of the requests I get for consults on ECGs actually come from left bundle branch blocks. And a lot of the misdiagnosed that I see also comes from left bundle branch blocks. So we're going to analyze this and see, okay. So a left bundle branch block can also be a hemi block. And if you'd like to learn more about hemi blocks, we have an older lecture that actually deals with it. So you can go back and have a look at that, where I talked about hemi blocks. But here we're going to talk specifically about this patient. So we've got a 66-year-old man with left shoulder pain and dyspnea. So in an emergency setting, you might be thinking about a pulmonary embolism. You might be thinking of a pleuritic type pain. And of course, you'll be thinking of a cardiac pain as well. So you run your ECG and this comes up. Now, for the majority of people in my department, when this comes out, they immediately send it to me and say, we don't know what's going on. Or is this an MI, or what are we worried about, So let's go through it step by step. So first, let's have a look at the axis. So we've still got an upward-facing lead 1 and a biphasic lead AVF. So we're looking more or less at it's within normal, let's put it that way. So in order to illustrate that, let's draw it out. So we've got our 4 quarters. I'm not going to label everything, just so that we know, more or less where everything is. So that's lead 1, that's lead AVF over there. All right, so we see lead 1 going positive. So we know that it's either going to be, so we know that it's either going to be, why is it not fine? Let me try that out again. So we know that it's just something not working for some reason. I don't know why. Yep. I'll just try it one more time. Right, so we know that it's either going in that direction or that direction, because we've got lead 1. And if we look at lead AVF, we can see it's biphasic. So remember what we said, when it's biphasic, we're looking at it more or less. Oh, it's doing it again. So when it's biphasic, it means that we see the lead F is basically seeing it move towards it and then move away from it, so to speak, So we've got an axis that's more or less around the 0. It's a little bit closer to the negative, but we won't get into that right now. But we've got a relatively normal axis. Let's look at the rhythm. So we start by looking at the P waves, and we can see our P waves are relatively normal. They a bit biased towards the left-hand side, but that's besides the point on this one. And we can see we've got a gap of about 4. So it's borderline first-degree heart block. Okay, so remember, between 2 and 4 is normal. Less than 2 is a problem. More than 4 is a problem. Okay. Our QRS complex is narrow or wide. They widened. All right. So what that tells you is that either there's a missing atrial response, or there's a block, as in this case. All right. So here we've got a left bundle branch block. All right. That's what's causing the problem. So basically what's happening is that as the electricity is passing through the left side of the heart, which is the majority of the heart, it's basically its conduction time is delayed. All right. Now remember, you've always got alternative pathways. You've always got ways that the electricity can travel, and especially when you've got a relatively complete block, well, it's not a complete block, but when you've got a bundle block and things like that, this is more or less what it looks like. Just these wide QRS complexes, although they are quite regular, and each one follows a P. So we've got a wide ventricular complex. Now, do we have a tachycardia? Let's look, 1, 2, 3, so 100. So we've got, well, you could say it's a query, a ventricular type tachycardia. It's not really a ventricular tachycardia, but it falls under that. Now let's look at each and every zone. So if we look at leads 2, 3 AVF, we see a little bit of ST depressions. Now, when we come to V1, V2, V3, or even if we look at 1 and AV, or let's look at AVR, we can see a slight ST elevation. But the problem is that when you have a left bundle branch block, the majority of the time, you do get ST elevations and you do get ST depressions. And that's what trips people up. Because regardless of whether the patient is having a myocardial infarct or not, because of the way that electricity is traveling through the heart, you tend to see these ST elevations in a lot of places and ST depressions. And this is what trips people up, because is this really an MI or not? So we're going to get into that. But let's just work according to our system now. So if we had to look at this, we've got V1, V2, V3, even V4, it could be argued we've got these large ST elevations, but in the presence of a left bundle branch block. So is it really something that we should worry about, or is it something that we shouldn't worry about? But it's already triggering in our mind, okay, listen, something's gone, something is going wrong here, and we're going to get into how you should look at it. Okay, so for right now, we're suspecting that we've got a myocardial infarct, but the question is why? This is actually a relatively easy left bundle branch block, but the question is why? Why are we looking at an anteroseptal or even a lateral infarct? Now let's look at the answer that was given. So we've got a sinus rhythm rate of 90, okay, so, occasional premature ventricular complexes. Do we really have those? Let me just check. Or maybe it does come out once in a while. Oh, I think they're just talking about these. Yeah. So we do have a premature complex of this. Sorry, I missed that. ST segment abnormality consistent with acute ischemia or MI. Now, this is the part that trips people up. So let's have a look and see what they talk about. So left bundle branch blocks are associated with characteristic repolarization abnormalities. So and as they say, all emergency physicians know this well. In all leads, ST segments are displaced in the opposite direction to the QRS complex. So what they're basically saying is that when you have a left bundle branch block, now your QRS is always going to go in one direction or the other. So it's either going to go up or it's going to go down. And when you have a left bundle branch block, because of the problems with repolarization, you'll always find that when it goes down, you have an ST elevation. When it goes up, you have an ST depression. So this is quite common in left bundle branch blocks. And this is what trips people up. Okay. So this is a left bundle branch block with normal or expected discordance. Now we need to look at that word. What is discordance? So discordance or expected discordance basically means that there's, let's say, an inverted QRS complex with an upright ST segment. So that's called discordance. Concordance would be when you have, let's say, an QRS complex that's inverted and also an ST that's going like this. So I'm going to try and draw it out so that you guys can get an idea of what I'm talking about. So concordance would be if the ST segment started from there, for example. That would be concordance. So you'd find everything, your ST segment would be there. Whereas discordance, let's turn it the other way around. So imagine if we had a QRS complex that looked like this. Okay, it's upwards, and then you have a ST depression that's going down there. That would be discordance. All right. So that's discordance, right? And then let's look at another example of concordance. So imagine the same thing. We've got, just trying to draw it. So we have a QRS complex that goes up. It's wide, and then it does that. So that's concordance. So concordance means your ST segment and your QRS complex are both upright or inverted. And discordance means one is upright, one is inverted. In other words, one is up, one is down, or one is down and one is up, as in this case. And concordance means both are down or both are up. That's basically what it means. All right. Now, discordancy and concordancy is quite an easy topic, quite an easy thing to grasp once you understand it. But we're going to get into why it's so important with left bundle branch blocks. So Dr. Sgarbossa. Now, Dr. Sgarbossa, one of the most amazing cardiologists the world has ever seen. She's Italian. She's written so many books, so many papers. But this was probably her biggest common usage criteria that she gave to the world. So she published a set of criteria which utilized the expected ST discordance to make predictions about the chances of a patient with left bundle branch block having an acute myocardial infarction. Now, I'm not going to go into all of this right for now, but we're going to have a look at it on the next one. All right. So let's just get into them. So these are Sgarbossa's criteria. All right. So Dr. Sgarbossa came up with this. Now, it has a scoring system as well. So remember, we talked about concordance and discordance. So basically, concordance is a bad sign, right? So in other words, if you have up and your ST is up, that's a bad sign. If your QRS is inverted and your ST is below, let's say, or is also down, that's also bad. So up is bad, down is bad. Up down, like what we have here, is not as bad unless it's above one block, one big block. Okay, so this is the easiest way to understand a left bundle branch block and to understand what are the chances of an acute myocardial infarction. Now, this has a little caveat. When we are dealing with a patient who presents to us for the first time and they have acute signs, so physical signs, pressure on the chest, diaphoresis, shoulder pain, whatever you want to, pressure between the shoulder blades, low BPs, whatever it is, and we get a left bundle branch block, regardless of whether Sgarbossa's criteria are there or not, but you have a left bundle branch block, you treat them as a new myocardial infarct. So you treat them exactly the same. Now, Sgarbossa's criteria are just to help you assess the likelihood that it is definitely an acute myocardial infarction. So let's take that one step further. You get a left bundle branch block, and on some areas, you see up. Chances are quite high. You see what you call it down. In other words, your QRS complex is inverted and your ST is starting off lower. That's a bad sign. And if you get a very high discordance, so in other words, you've got a down up in this case, but it's quite a big down up, then it tells you that that is quite bad. Now, in terms of the point system, yes, of course, the more points you add, the greater it is. But in the emergency setting, we basically take up or down as bad. We assume that it is an MI. If we have up down, but quite bad, we assume that it is an MI as well, and we treat the patient as such. The good part about treating a patient as though they are myocardial infarct is that the worst that comes to worst is that you are going to either thrombolize or catheterize a patient who during the angiogram would show up not to have a blockage, or post thrombolysis, just so long as you've gone through all your indications and contraindications, relative contraindications, your patient will be relatively safe. Okay. But an MI can kill them. All right. So here we see again, you've got concordance, so up, QRS complex up, ST up, concordance. QRS complex down, ST down, concordance, right? So this is in V1, V2, and V3 that they're talking about, and concordant in any lead that they're talking about. So I must be honest, you will see this mainly in lead V1, V2, and V3. It's not very common to see it out of that. And then a discordant ST elevation greater than 5 millimeters in any lead would immediately start telling you this could well be a myocardial infarct. Now, why I'm spending a bit of time on this is because this is what trips people up. So if we go back to our ECG, what we see is that we've got V1, V2, V3, discordancy, all right? And the discordancy, as you can see, it's greater than 5 millimeters, all right? So let's go back to what they were talking about, all right? So the distance from the neutral line, or let's say the zero line, to where the actual ST is greater than 5 millimeters. So is that the case? Yes, you can see it's almost 1.5 blocks here. Even in this, well, this one's not as pronounced, but in V2, V1 it is, and here, if you come, like, for example, to lead 2, you can see it's not as pronounced, even though it is there. So it starts to tell you that something is going on. Now, the question is, all right, so I've seen this, now what do I do? The whole reason for doing this is assuming that the patient does have an acute myocardial infarction, and to treat the patient as such, which is something we've discussed before when we talked about chest pain and acute management of chest pain. So this is the type of patient that you would now give nitrates to. You would start on morphine, you would give clopidogrel, you would start working them up either for thrombolysis or catheter or for the cath lab, depending on where you work. And that's actually what this is supposed to trigger off. As compared to a patient who's come in completely asymptomatic, coming for a routine checkup, has had this many times before, you've got a history of left bundle branch block, and now you see another one coming out, and you compare it to an old ECG and it looks the same. That tells you that, listen, this is not a new event, this is an old event. So that's the basic thing that we're trying to determine. Is this an acute event or is it not an acute event? Now, in a patient who's, for example, let's say not being seen by your hospital, clinic, practice, whatever it is, they've been in another state, province, country, whatever it is, they have no idea. They just know they've had ECGs before. And if you were to see something like this and they presented with signs and you were to manage them as an acute MI, medico-legally you are covered because you're actually following the norms and standards of the medical community. However, if a patient comes in with a history of left bundle branch block, no acute symptoms, and you still treat them as an MI, and then something goes wrong, you are then liable. So that's why we need to know about it. All right. So like I say, it's quite scary to see a left bundle branch block because everything looks wrong. That's the thing. So what we're going to do is we're going to try another one. All right. And if you want to, pause at this junction and try and figure it out yourself, and then we'll go through it as well. Okay. So if you want to pause right now, okay, that's good. Right. So let's go through it. So we've got here leads 1 and lead AVF here. And we can see that lead AVF is pointing negatively, lead 1 is pointing positively, so we've got a left-sided axis. All right. If we have to look at the rhythm, just to make it short to get to what we really need to look at, we're actually looking here at a Morbitz type 1. Okay, so if you that sounds a bit confusing, you can go back to it and have a look, and you could argue that we've got premature ventricular complexes here. We've got a relatively slow rate of about 60, but that's not what we're interested in. All right, so let's go through each and every section of the ECG, knowing what we know now about discordancy and concordancy. So if we look at the inferior leads 2, 3, and AVF, what we see is discordancy. Now, this is a left bundle branch block. We know this because we've got widened QRS complexes, and it looks like a left bundle branch block. So what we have now is that we have discordancy, but as you can see, it's not above 5 millimeters. So this doesn't tell us much. It just tells us that the left bundle branch block is there. If we were to look at AVR, again, we see a discordancy here, where we've got QRS going up, ST is a bit down, but it's not that pronounced. Now, when you come to V1, again, not much to talk about there. But once we come to V2, V3, and V4, we notice concordancy. So what we have is a QRS complex that's going down, and we have an ST segment that is also in concordance with the QRS complex. In fact, it's there even in V5 and then disappears by V6. So this tells us that we've got an anterolateral, let's say. because it's just starting to affect the lateral side as well. We've got an anterolateral myocardial infarction in the presence of a left bundle branch block. Now, you won't see reciprocal changes, for example. You won't necessarily see a lot of the classic signs that we've seen of myocardial infarctions, because this is what you need to look for: discordancy and concordancy. And you can see once you look at it, suddenly it's a whole lot easier. In fact, left bundle branch blocks are quite easy to read in terms of a myocardial infarct, because literally you are only looking for those criteria. You're only looking for concordancy and discordancy. You're not looking for reciprocal changes. You're not looking for spread to the right-hand side. You're not looking for posterior spread. You're not going to do a right-sided ECG. You're not going to do a posterior ECG. You know that you have an infarct and you know how to treat the patient going forward. Okay, so they actually become quite easy once you have a look at them. But it's to get to that point that's the problem. So if there's one thing that you want to keep in your head from this, remember, concordancy, bad. Discordancy, good, unless it's very, very large. Okay, so remember that. Concordancy, up, up is bad. Down, down, bad. Up, down, good, unless the difference between the up and down is quite pronounced. Now, this is by no means an exhaustive talk about left bundle branch blocks and their pathophysiology and how you go through them. It's just merely to give you a basic understanding of how to go through it. There's a lot. There's a lot. You can go into left bundle branch blocks for hours, actually, but I don't want to overload you. So what I want you to do is rather have a look at this, understand this part of it, so that the next time you get the left bundle branch block, you now know what to concentrate on. Now, we still go through all of the criteria that we normally do. We look for an axis, we look for rhythm, we look for rates, we do all of that. But now you know that you've got to look for concordancy and discordancy. So now if we go back to our initial ECG that we had, suddenly looks a lot easier, because now you realize you've got discordancy, V1, V2, that is quite severe. So there is a very good chance of an MI here. And this, what you are seeing here, is not reciprocal changes. These are not reciprocals. These are as a consequence of the left bundle branch block. Okay, so I hope everybody understood that. And I know it's something that can be confusing sometimes, but it's actually quite easy once you realize what you've got to look for. So don't let left bundle branch blocks scare you, because they look so scary. Now you know what you've got to look for, and I'm sure all of you will be able to pick it up. So that's just a joke, just to finish up. And unfortunately, our patients do this. Now, hopefully in the next coming weeks, we're going to have a look at some other left bundle branch blocks. I want to discuss left bundle branch blocks in a bit more detail, so that you understand a bit more of what's going on behind them. But I hope you guys enjoyed it, and I hope you learned something. Until next time, keep well. Bye.